Welcome to the presentation, Utilizing Point-of-Care Ultrasound at the Patient Bedside, Hitting Healthcare Like a Tidal Wave. It is an incredible time to be a respiratory therapist right now. I am an advocate for maximizing our scope of practice. The RT profession is unique in that our scope of practice is very broad. Most states recognize that we can do pretty much anything as long as we have a competency for it. In July of 2015, the AARC released a position statement supporting the use of RTs as vascular access specialists. The respiratory therapist education provides extensive training in cardiorespiratory anatomy, physiology, and pathophysiology. These fundamentals of respiratory care education make the respiratory therapist uniquely qualified to undertake further education to be competent in this procedure. I graduated from a respiratory program in 2007. Neither vascular access nor point-of-care ultrasound was even discussed in school. I attended a workshop put on by the Texas Society for Respiratory Care in 2017 that was promoting the concept of implementing internal RT-driven vascular access teams. This event introduced me to the point-of-care ultrasound technology, also referred to as POCUS, and it quite literally changed the trajectory of my career path. I was a bedside RT for over a decade before I learned about RT vascular access specialists and point-of-care ultrasound. My goal for this presentation is to spread the word amongst RTs and really get the conversation going. Historically, RTs have worked in silos. It's time to capitalize on the opportunity to learn from each other's success stories and even learn from our failures. I, Callie Johnson, do not have any current or past relationships with commercial entities. While I will talk about different point-of-care ultrasound machines that I have experience with, I do not recommend the use of one brand over another. A special thank you to MedCram, POCUS Geek, and Joseph Minardi for the use of videos for this presentation. Also thank you to respiratory therapists Teresa Ressel-Griego and Courtney Shelton for their photo contribution. POCUS has come so far, and there are tons of options to choose from. If your team is considering purchasing a system for your department, I encourage you to explore your options, from the larger, more advanced systems that now offer artificial intelligence to the more portable and compact models, one of which you can plug directly into your smartphone. Today we will discuss the benefits of learning to use point-of-care ultrasound. I will talk about the history of the technology. At the end of this session, participants will be able to recall specific examples of different ways we can use POCUS in our respiratory care practice. We will go over the equipment's parts and which probe to select for specific exams. Correct technique and how to interpret images will be explained. At the end, I hope you will decide that learning to use point-of-care ultrasound can improve the care you deliver to our patients. Ultrasound technology has been around for a very long time. Way back in 1794, echolocation was discovered by Lazzaro Spallanzani. Echolocation is used by bats. Bats use echolocation to navigate and find food in the dark. To echolocate, bats send out sound waves from their mouth or nose. When the sound waves hit an object, it produces echoes. The echo bounces off the object and returns to the bat's ears. Similarly, ultrasound machines are used for taking images by using sound waves that are transmitted to a computer screen as an image. It allows the practitioner to visualize anatomy in real time. You can measure the size of and assess the depth of various anatomical structures. Ultrasound has experienced many milestones throughout its evolution. POCUS uses piezoelectricity that was discovered in 1877 by Pierre and Jacques Curie. In the POCUS probes, there are one or more quartz crystals called piezoelectric crystals. When an electric current is applied to these crystals, they change shape rapidly. The rapid shape changes, or vibrations, of the crystals produce sound waves that travel outward. The hydrophone was invented by physicist Paul Langevin, and it's kind of served as a stepping stone to modern-day ultrasound technology. As sonography developed, it was used to treat European soccer teams. In 1942, neurologist Carl Jusick first used ultrasound as a tool to diagnose patients. Dr. Inge Edler performed the first echocardiogram in 1953, a procedure that is still routinely performed on patients today. Then in 1958, ultrasound was introduced to the OB/GYN world, and we are now able to visualize babies in the womb. It allows us to evaluate for birth defects and find out the gender prior to the birth so that the parents can plan for bringing their new baby home. Ultrasound technology evolved into 3D ultrasound technology in the 1980s. And in 1989, Dr. Daniel Lichtenstein added POCUS to bedside patient assessment. As I said before, ultrasound technology actually started by studying bats. It developed into a specialized skill. Ultrasound technicians make a living at using the technology for various ultrasound examinations. Today, the miniaturization, ease of use, and the evolving affordability of ultrasound have now made this technology widely available. It's no longer limited to just sound and touch. POCUS offers an actual visual image. The butterfly point-of-care ultrasound probe, seen here on the left, can literally transform your cell phone into a point-of-care ultrasound system. It's arguably not only the most portable POCUS option, it's also the most affordable, on the market for only a couple $1,000s. If your department has deep enough pockets to afford tens of thousands on a POCUS system, the Venue or the Venue Go may be the better option. As the newest member of the GE Healthcare family, Venue Go features several artificial intelligence-powered tools that facilitate the evaluation of ultrasound scans by automating several tasks. Sonosite also has a comparable system that you may have seen in your hospital's critical care unit, in your emergency department, or procedural and surgical areas. I first started using POCUS to help guide arterial punctures for blood gases. Starting out, I thought I would have trouble finding available equipment. It actually turned out that my hospital's PACU had 4 POCUS systems just sitting around collecting dust. I reached out to our chief of medical staff, who happened to also be an anesthesiologist, and he immediately agreed. He told me, most of my staff doesn't even use them because we hardly ever miss. I explained to him I would be collecting data and developing a performance improvement project, comparing traditional blind stick palpation method to the ultrasound-guided approach to arterial punctures. Although the thought that using point-of-care ultrasound was a waste of time, he said he would be interested in reviewing the results of my project. And to his surprise, my project revealed that introducing point-of-care ultrasound to needle puncture procedures improves first-attempt success rates and actually decreases the time required to successfully perform the procedure. Depending on what type of machine you have access to, this might look a little different. Every POCUS will have a screen, whether it's the screen from the manufacturer or the screen of your own personal cell phone. You will need ultrasound gel. I currently work full-time as an accreditation clinical coordinator, so my regulatory hat feels obligated to remind everyone if you are using these reusable ultrasound gel bottles, be sure that once it is opened, it is labeled with a beyond use date. Most commonly, it should be labeled with the date 28 days after opening and should be discarded after that date. These reusable bottles are fine to use for bedside patient assessment when you are not performing any kind of invasive procedure. If you are using ultrasound to assist with an invasive procedure, you should be using individually packaged sterile ultrasound gel packets. Additionally, you should also use a probe cover for any invasive procedure, even procedures as simple as arterial blood collections. The linear array probe is what I have the most experience with. It is the probe that I use to guide arterial punctures. The straight linear array probe is designed for superficial imaging. The crystals are aligned in a linear fashion with a flat head and produce sound waves in a straight line. The image produced is rectangular in shape. This probe has high frequencies, 5 to 13 megahertz, which provides better resolution and less penetration. This probe is ideal for imaging superficial structures and in ultrasound-guided procedures such as needle puncture procedures, including blood collection, vascular access, thoracentesis, and paracentesis procedures. Additionally, the linear probe is the best choice for assessing the chest for a pneumothorax. If you are a woman who has given birth, you probably have come into contact with the curved array probe. A curved array transducer has a curved surface, creating a field of view that is wider than the footprint of the linear probe, but at the cost of reduced lateral resolution in the far field as the scan lines diverge. The curved array probe is ideal for abdominal ultrasound. RTs that frequent the emergency department have probably observed the phased array probe in use. It is the cardiac probe that ED providers use to check for cardiac activity during and after cardiopulmonary resuscitation efforts. The use of ultrasound is no longer exclusive to ultrasound technicians and physicians. The technology is readily available to many other disciplines responsible for patient care, including mid-level providers, nurses, respiratory therapists, paramedics, phlebotomists, organ donation specialists, vascular access specialists, and physical therapists. It is important to establish and maintain competency. POCUS was named as one of the top 10 medical technology hazards for 2020. Safeguards for ensuring that POCUS users have requisite training, experience, and skills have not kept pace with the speed of adoption. It's not the technology itself that is dangerous. It is the lack of oversight over practitioners using the technology. There are so many applications that RTs can utilize POCUS for. We can use it to guide simple arterial punctures. And if you are fortunate enough to work at a facility that recognizes RTs as vascular access specialists, you can learn the skill and use it for ART lines, peripheral IVs, midlines, PICC lines, and central venous catheters. There is an RT team in Midland, Texas that is currently learning to use POCUS to guide needle punctures to place tunneled dialysis catheters. It is always recommended to use a probe cover when utilizing point-of-care ultrasound to guide needle puncture procedures. Even for simple phlebotomy or arterial blood collection, a probe cover should always be used. When you puncture the skin with the needle, you should put the needle as close to the midline arrow as possible. Slowly advance the needle, and as it goes deeper, you will need to push the probe ever so gently away from you to follow the needle on the POCUS screen. If you are viewing the radial artery and your patient has normal anatomy, you will see the Mickey Mouse sign with the radial artery in the middle of two veins. Keep in mind, though, that not everyone has normal anatomy, and you will come across anomalies. One of the instructors at the workshop I attended in 2017 actually had two radial arteries lying right next to each other. So if you attempted to puncture this young man's radial artery, you may palpate a wide bounding pulse. And when you stick, you may not get a flash because your needle may have landed in between those two radial arteries. Even on healthy young individuals, how do you know who is an easy stick or who is a difficult stick before you attempt to collect blood or start the line? I do understand that there are tools that have been developed, such as the DIVA, the Difficult Venous Access Tool, to help identify difficult stick patients. But after adopting a no blind sticks promise in my own practice for 2 years, I challenged the validity of these tools. In my own experience, assessing whether a vessel is visible or palpable and the age of the patient has not served as a reliable predictor as to whether he or she will be a difficult stick. Learning to use point-of-care ultrasound can highlight respiratory therapists' advanced practice skills and help us gain credibility, especially in critical care and emergency department units. While I was working on my performance improvement project, we created some serious buzz throughout the hospital and ultimately across our entire healthcare system. Nursing staff and providers were very intrigued by these respiratory therapists running around the place with point-of-care ultrasound machines. I had several employees from different departments and even physicians ask about what we were doing with this POCUS system, and many requested to observe the procedure. Utilizing POCUS to guide deep needle puncture procedures was recognized as a best practice almost 2 decades ago. I truly believe in expanding that best practice to include all needle puncture procedures, including simple phlebotomy and arterial punctures for blood collection. Blood draws are the single most invasive procedures performed in hospitals. Roughly 760 inpatient blood draws are performed every minute in the United States. Additionally, blood donation centers can benefit from adopting a no blind sticks mentality. The American Red Cross currently reports a critical shortage of blood in America's blood banks. The number one reason people do not donate blood is due to a fear of needles. Point-of-care ultrasound can help alleviate that fear. If American blood centers utilize point-of-care ultrasound for blood donation, the technology could potentially expand the donor pool by 24.8 million blood donors. Okay, so we've talked about how point-of-care ultrasound can be a useful tool to guide needle puncture procedures. RTs can also utilize the technology for bedside patient assessment. POCUS can help examine a patient at the bedside in real time for a pleural effusion, pericardial effusion, pneumo or hemothorax, interstitial syndrome, pulmonary edema, and to analyze the inferior vena cava. The images seen here illustrate A lines and B lines. A lines are expected to be seen in a normal ultrasound lung exam. B lines appear similar to rays of sunshine beaming down and are visualized on exams of patients who are fluid overloaded. There are 10 basic signs to recognize on lung ultrasound. They include the bat sign, the seashore sign, A lines and B lines, lung rockets, the quad sign, the sinusoid sign, the shred sign, tissue-like signs, the barcode sign, and lung points. The bat sign helps us to identify the pleural line as a good starting point during thoracic exam. The seashore sign, with its sandy beach appearance, is visualized when normal lung sliding is present. We touched briefly on the previous slide about A and B lines. Lung rockets simply refer to when you place the probe on the chest and you can see 3 or more B lines in that same image. If your patient has a pleural effusion, you may see the quad or the sinusoid sign when fluid exists between the visceral and parietal pleura. On your critically ill multifocal pneumonia and ARDS patients, you can visualize what is called the shred sign. The shred sign refers to small subpleural scattered hypoechoic areas with an irregular deep border. While the shred sign indicates non-translobar consolidation, the sign of translobar consolidation is known as the tissue-like sign. The barcode sign is also called the stratosphere sign, and it indicates the presence of a pneumothorax. Using point-of-care ultrasound is the fastest way to diagnose a pneumothorax, and you don't even have to expose your patient to radiation. Finally, a lung point is a place where the practitioner can see where a pneumothorax ends, and normal sliding can be seen in that same intercostal segment. To start your point-of-care ultrasound thoracic examination, if your patient can tolerate it, the best position is supine and flat. Select the appropriate probe for the exam you want to perform. Use a cephalocaudal orientation, and with the linear probe, you should be able to see an entire rib space with rib shadows on either side. Examining the chest in this fashion is the fastest way to assess for a pneumothorax. It eliminates the need to transport your patient to radiology, and you don't have to wait for the radiologist to interpret it. You can jump right to a bedside diagnosis and treat pneumothoraces immediately. If you do not observe lung sliding, your patient may have a pneumothorax. Keep in mind that it is important to get a thorough patient history. Pneumothorax is not the only reason that you may not observe lung sliding. For example, if your patient has a history of recurring pleural effusions or recurring pneumothoraces, he or she may have undergone a pleurodesis. Pleurodesis is a medical procedure in which the pleural space is artificially obliterated. It involves the adhesion of the two pleurae. So now that you have more knowledge on the purpose and technique of adding POCUS as a tool for bedside patient assessment, let's interpret this examination. Do you see any abnormalities in the images on this slide? If you said no, great job. This is a normal lung ultrasound. The picture on the left illustrates a pleural effusion and lung consolidation. The picture on the right demonstrates B lines that appear like sunshine rays. Notice that 3 B lines are shown, so together they can be called a lung rocket. This patient may exhibit audible wheezing. How many times have you been called by a bedside nurse for a breathing treatment on a patient that you knew was wheezing due to fluid overload? This situation offers a great opportunity to do some real-time education with nursing staff. Perform a bedside point-of-care chest examination and show the nurse that he or she may want to call the provider to get an order for a diuretic. Albuterol is not going to help this patient's cardiac wheeze. Albuterol is only, of course, recommended for true bronchial wheezing. To help you assess intravascular volume status, you can analyze the patient's inferior vena cava. I used this method a lot when I worked as an organ donation coordinator. I had other tools available to me, such as a central venous pressure reading and non-invasive equipment like the Cheetah monitor. But what I found was that using ultrasound to capture IVC measurements, I was able to balance my donor's fluid status faster. To analyze the IVC with POCUS, first measure the width of the IVC during inhalation. Now, of course, I couldn't do this with my donor patients, but if your patient is coherent, ask the patient to inhale or sniff to capture the most accurate measurements. Then measure the width of the IVC during exhalation. Compare the two numbers. If there is a difference of greater than 30%, consider administering fluids. If the difference is more than 50%, definitely administer fluids. And then after the fluid bolus completes, reassess the IVC measurements. These pictures are my attempt at illustrating the difference between a cardiac wheeze and a true bronchial wheeze. The image on the left is an airway of a patient in fluid overload. You can probably hear this patient audibly wheezing from the nurse's station. But a bronchodilator is not going to do anything for this patient, except maybe give him or her some tachycardia and shakiness. The reason is there is nowhere for the airway to dilate. because the pressure from the extra fluid is applying pressure from the outside in. The image on the right is what a true bronchial wheeze looks like. The airway is constricted and inflamed. When you administer an aerosolized bronchodilator to this airway, it can open up and the wheezing should improve. Dr. Razak Badamosi from a hospital in Fort Worth, Texas, once advised a group of respiratory therapists, if you are not evolving, you are going extinct. Rutgers University in New Jersey created an integrated blood analyzer. The device includes an ultrasound image-guided robot that draws blood. As a healthcare professional, it makes me very uncomfortable to think that a robot could take over some of my job responsibilities. Also, especially with patient satisfaction scores, now having such a huge impact on reimbursement, we need to try and maintain that human touch and really enhance the patient experience. Point-of-care ultrasound technology is readily available. Practitioners just need to take the time to learn it. I encourage you to find out who the experts are at your hospital. For me, it was the paramedics who worked as techs in our emergency department. Although nurses have the opportunity to learn this skill, specifically for starting peripheral IVs, what I discovered was that most chose not to. The paramedics were all over it though. They were proficient at both the transverse and longitudinal views, and they were happy to help. Even on days when I wasn't assigned to the ED, they would call me on Vocera to see if I was available to come down and practice the skill. If you are wondering if learning this skill is worth your time, the short answer is yes, definitely yes. If you need more convincing than that simple black and white answer, consider the following. If you work in a hospital, I'm sure you have heard the term operating lean. Hospitals across the country are asking staff members to come up with ideas that save the hospital money while maintaining a level of excellent patient care. I was fortunate that my hospital introduced me to the Lean Six Sigma program. If your healthcare system offers these lean programs, I encourage you to get involved and learn more about tools like Lean Six Sigma's DMAIC process. The DMAIC process can be applicable not only to your professional career, it also can be useful in your personal life. Whenever you have a problem and you don't know the best solution, you can go through the DMAIC process and you will discover a suitable resolution. Both respiratory therapists and nurses can place and manage vascular access devices. Nurses are responsible for so much, and in a lot of healthcare facilities, they are spread extra thin. Contracting vascular access services out is expensive and can contribute to increase in central line infection rates. After I became proficient in utilizing POCUS for needle punctures, I started to almost feel like I was cheating. The technology gives you such a clear picture and accurate depth measurements that I realized how impressive it is that RTs have historically been so great at sticking blindly. In researching RT-driven vascular access teams, I have connected with leaders from 15 different RT-driven vascular access teams in 7 states across the country. Their programs are flourishing, and I feel so privileged to be able to connect with them and hear their success stories. When senior leadership realizes RT's advanced practice expertise, it really opens the door to additional opportunities. Several hospitals that added RT vascular access teams subsequently included endotracheal intubation programs and ART line management. Just by learning to use point-of-care ultrasound and implementing the technology into your practice, you can create a buzz around your hospital that can help get conversations going. I experienced personally that when I would walk into a patient's room for a blood gas, there was a definite sense of relief when I brought the POCUS system with me. Patients are becoming more and more familiar with point-of-care ultrasound. They are starting to request it, especially in the emergency department. Oftentimes, the patient is so looking at the POCUS screen that they don't even notice the needle stick. As we all know, CMS reimbursement tied to patient satisfaction scores. Using point-of-care ultrasound has been proven to increase those ratings. RTs that learn to use point-of-care ultrasound and routinely carry the technology with them throughout the hospital will definitely create a buzz. POCUS has been proven to decrease complications. It is the fastest way to diagnose a pneumothorax, and it has 0 contraindications. When I decided to conduct a study comparing traditional blind palpation arterial sticks to ultrasound-guided arterial sticks, I thought that finding a machine to use was going to be a barrier. What I learned was that departments were happy to share. If your department decides to purchase its own machine, there are affordable options available, some as low as a couple $1,000s. I mostly used PACUS equipment, but there were times when I was in ED and it was just more convenient for me to use their system. My hospital also had a community POCUS machine housed in a central location of the hospital that was available for checkout. So I encourage you to look around, be assertive, and find out who has point-of-care ultrasound machines in their department. They may be underutilized. Remember to be courteous when borrowing equipment. Become familiar with the manufacturer's cleaning recommendations and replenish supplies after you use them. My current full-time job is in regulatory. I'm an accreditation clinical coordinator. So my department conducts frequent regulatory tracers. A common finding on our tracer rounds is the storage of ultrasound gel. Manufacturer recommendations state that ultrasound gel bottles should be discarded 28 days after opening, and the expectation is that bottles be labeled with a beyond use date. When Joint Commission comes to survey, if they find opened bottles that have not been marked with a beyond use date, they will write it up as a finding. For this reason, many hospitals have moved towards single-use packets of gel. If you are using ultrasound to guide needle puncture procedures, you should always use the sterile single-use packets. Multi-patient use ultrasound gel bottles are okay to use for bedside patient chest assessments. Just make sure the bottle is labeled appropriately. Probe covers protect the patients, the clinicians, and the ultrasound probes. It is recommended to always use a probe cover especially when you use POCUS to guide invasive procedures. There are so many great resources out there to learn more about implementing point-of-care ultrasound technology into your practice of respiratory therapy. I appreciate everyone who contributed to this presentation. I will continue to advocate for maximizing our scope of practice, and POCUS offers a giant leap in that direction. Thank you so much to MedCram, Dr. Jared Marks, and Joe Minardi for the use of their videos in this presentation. Email your answers to this post quiz to receive your CRC certificate electronically. List 3 healthcare professions that can utilize point-of-care ultrasound in their practice. Name 2 applications that respiratory therapists can use POCUS for at the patient bedside. When using POCUS to rule out a pneumothorax, after identifying the pleural line, what should you look for next? When using POCUS to assess intravascular volume, if the width of the inferior vena cava changes by 50% when comparing the size on inhalation versus exhalation, what does your patient most likely need? Thank you so much for participating in this webinar today. I hope you enjoyed the content and learned something new. Please email your post-quiz answers and any questions you may have to heroesofhealthcare@gmail.com.